It's 36 hours after Hurricane Katrina has blown through the Big Easy. You are one of 35 federal medical officers who are arriving at 9:38 a.m. in the Louis Armstrong. Unfortunately for you, your flight line went active at 7 a.m. So you know where your colleagues are right now. Let me describe your flight line. Far to your left, you have what you're used to seeing, BKs and ACs. Two-person helicopters, 2 patients at a time at max if you stack them right. Usually just 1 at a time. Right down the center flight line, simultaneously, you have something that you're not used to seeing in the civilian world. Blackhawks, Dolphins, and Sea Kings. 8 to 10 patients or evacuees per load. On the far right-hand side of your flight line, you have something that only a few of you may even have been born when you last saw them in large-scale use. It's called a Chinook. It has 2 rotors, a huge drop-down tailgate, and carries 80 patients or evacuees, even on litters, at a load. That's 80 plus 8 plus 2 or 90 people. You're rotating your flight line every 10 minutes. That's 540 people an hour in a 12-hour shift. That's your incoming surge for the next 5 days, on top of 5,387 people that have yet to be triaged. Emergency Severity Index. That's that 1 through 5 that you see used in the hospital. Straight out of the instructor's manual, ideal training says you should be able to triage 1 patient every 8 minutes. Now with 5,387, do something a little faster. But because you have been well trained, you know that there's something else. There's start or jump start. If you just can't walk past a dead body without opening an airway and blowing in it 2 to 4 times. And you know out of that manual, 30 seconds per. But we're still talking then about over 2,700 minutes. But again, you are triage professionals. You absolutely know that you can use integrated triage. You can take mass, move, assess, sort, and send from the military and get rid of 80% of those patients in a matter of a couple of minutes. Now, I don't know about you, but my favorite triage device, my favorite medical instrument to perform a triage with is a bullhorn. You will pick up that bullhorn and you will announce, if you can hear the sound of my voice, follow Kate to Concourse A. And lo and behold, 80% of everybody will get up and will follow Kate to Concourse A. You've just gone from 5,387 people to just a hair over 1,100 that quickly. You then announce, if you couldn't follow Kate, please wave an arm or a leg at me so I can find you. I'll be right over to check you eventually. Because the people who got up and walked, they have declared themselves green tag, minimal. They are alert, oriented, ambulatory. They can maintain an upright posture for 60 feet while moving 2 major motor groups against gravity. Their care can wait. More importantly, they can be evacuated. Those that just could wave their arm and a leg, they've declared themselves yellow. They are alert, oriented, following commands, but they're non-ambulatory. But they can move at least 1 major motor group against gravity. They do require some care before they can be evacuated. But their care can wait, just not as long. At the airport, we found another group. We'd walk up to them, I'm going to touch you here, and we go, Annie, are you okay? And they would shoot through the ceiling. Asleep. Green tag, follow Kate, Concourse A, end of the line, you are not paying attention. Once you have moved those folks, you need to switch systems. Because now you have to go person to person. You move to start. simple triage, and rapid treatment, which is based on RPM, respiration, pulse, and mentation. You walk up to somebody, if they have a respiration in the normal range for an adult, 12 to 20, age appropriate in a child, move to the next criteria. If they have no respiration, they are dead. Move to the next patient. CPR is contraindicated in the event of mass casualty and disaster. Since 1997, American Heart Association, the American Red Cross agrees, World Health Organization agrees, and every major military medical organization in the world agrees with this statement. But if you are one of those individuals who cannot walk past a dead body without opening the airway and blowing in it 2 to 4 times, provide 2 to 4 rescue breaths. If they breathe spontaneously with no plastic inserted, then insert appropriate plastic. That's a nasopharyngeal airway or an oropharyngeal airway. Move them to the red tent and save their life. If they do not breathe spontaneously with a manually maintained airway, they are dead. Move to the next patient. Save the next life. If they have respirations that are present, but they are not in the normal range, 12 to 20 in adult, age appropriate in a child, red tag, red treatment area, save their life. If their respirations are in the normal range, 12 to 20 in adult, age appropriate in a child, move to the next criteria, which is pulse. If their pulse is in the normal range, 60 to 100 in adult, age appropriate in a child, move to the next criteria. If they have no pulse, they're dead. There is one and only one exception to this. Known organophosphate-based nerve agent toxicity. Maybe if you're in the Midwest, you could get away with organophosphate pesticide. In that circumstance, give them 1, 2, 3 Mark 1 kits. That's atropine and 2-PAM. Circulate it with CPR for 1 minute. I would recommend against mouth-to-mouth in these people. One of two things will occur. They will either get up and be very angry with you, but they'll have a pulse and be breathing, or nothing will happen, they're dead, move on. If, on the other hand, they have a pulse, but it is not in the normal range, 60 to 100 in adult, age appropriate in a child, they are a red tag, moving to the red treatment area, please save their life. If they have a pulse in the normal range, 60 to 100 in adult, age appropriate in a child, move to the next criteria, which is mentation. Now, mentation falls into 3 categories. You are either conscious, alert, oriented, following commands, ambulatory but not paying attention, concourse A, following Kate, green tag. End of the line. You are conscious, alert, non-ambulatory, following commands. Yellow tag. Now you'll notice I did not ask them what their baseline was. I did not ask any medical history at all because I do not care at this level. Because this individual will require some assistance to move through the rest of the medical care system. They will be re-triaged because triage is a continuous event. It is not a one-time thing. In fact, you have been triaging me since I first appeared in front of you today. And in fact, you've been doing 2 types of triage simultaneously. Now, some of you are looking at me again dubiously. The nurses in the room and the paramedics in particular, I've been to lunch with you guys. And I know what happens as soon as the little waitress leaves the table. You all look at each other and you say, I could put an 18 gauge in that with my eyes closed with both hands behind my back. You're always triaging like this. It is second nature. You triage, in fact, in 2 ways. I've been standing up here and you've been going manic or motivational speaker. And you do that every day when you walk in. You do that even if you wanted to turn it off, you couldn't. Because triage is a continuous event. So this person is yellow because they have to move through. They will eventually be re-triaged up or down. Don't worry about it. The only people that leaves, if you have taken your greens and your yellows out of the mentation, are those who are unresponsive, disoriented, or comatose. Because all the dead people you got rid of before them. Those people will fall into one of 2 categories. And it is dependent on one and only one thing. The resources you have available at that moment. It is a medical decision based solely on resource. They will either be red tag, critical, move them to the red tag area, save their life, or black tag, expectant. But they will be continuously re-triaged.